So thank you very much for the invitation to come to speak to you today at the Abu Dhabi Anesthesia Club. I'm going to talk to you about an introduction to nociception monitoring. I've got a few disclosures just to let you know about just ongoing support from the following companies, but shouldn't really have any issues with what I'm going to speak about today. So as Dr. Yasser said, my name is Anil Hormis. I'm a consultant in anesthesia, critical care medicine. I also work as a consultant in major trauma in pre-hospital emergency medicine, and I am a professor in emergency and critical care medicine in Sheffield. For those of you who don't know where Rotherham is, we're kind of in the middle of the UK. Our biggest city close to us is Sheffield, and you can see on the bottom right there where our hospital is. So over the next maybe 35 minutes or so, I'd like to discuss the following areas. This concept of precision anesthesia, which I've been practicing now for a number of years. We'll have an introduction into what exactly is nociception. I'm going to talk to you about a monitoring device which measures the null index. And I'm going to then go through 3 case studies, hopefully to show you how I've been using this particular set of monitors moving forward. So, as I said, the first thing to talk about is this concept of precision anesthesia, which I think is the way that we should be giving all general anesthesia in 2022. And we're going to talk a little bit about advanced monitoring that we can use to make ourselves undergo this. The first thing I want to talk about really is perception versus reality. And I think anesthesia, we know, is a combination of skill and science and a little bit of an art form. But these days, we should hopefully be relying on monitoring that will let us know that our patients are deeply asleep, they are well analgesed and well relaxed. And I think as I'm going to talk through the next sort of 30 minutes, you'll understand that a lot of it is down to our own perception and very subjective what we do. We all are aware of the TRIAD of anesthesia. We teach all of our students about this concept of the TRIAD of analgesia, hypnosis, and muscle relaxation. And for a number of years now, we've had monitoring for 2 of these domains. So muscle relaxation was the first monitoring that became available in the 1970s. And now this is an example of the tetrograph machine, which gives us continuous neuromuscular blockade monitoring so that we can constantly monitor our patients. In the next domain, we've got hypnosis. And again, I'm sure you'll all be familiar with processed EEG. I use the BIS monitor, although there are several other monitors that can be used. And this gives us very, very useful data looking at raw EEG, as well as the density spectral array, which you can see on my slide there. So this is all adding to making sure that our patients are in the right plane of anesthesia during surgery. But the problem is for analgesia, we've never really had a true monitor. We've never really been able to get something that will let us know how well analgesed our patients are during major surgery. And we use our own ideas about how much opiates we should give patients. And the problem with that is that there's lots of data to show us that there's a big interpatient variability between how we metabolize and how we need opiates during anesthesia. And the concept of a milligram per kilo dosing is very unreliable. And if I was to give each and every one of you on this call 10 milligrams of morphine as an example, there would be up to a 30-fold variation in how we'd all metabolize it. The pharmacokinetics involve the size of the stimulus, how the patients perceive stimulus, and also how our bodies react to the stimulus. So we really do need a monitor that can give us some ideas into how we are metabolizing and using the opiates. The problems is if we underuse analgesics, we have lots of problems in the PACU. We have hypertension, tachycardia, severe post-op pain. And I am sure that our next speaker will be talking about this concept of sensitization that can cause persistent post-op pain. And if we overuse analgesics, we have problems in recovery as well with hypotension, bradycardia, respiratory depression, post-op nausea, vomiting, and again, this kind of idea of opioid-induced hyperalgesia, which can be there as well. And overall, I think the main sort of reason I want to talk about this really is to change the focus of what we do within general anesthesia for major surgery and look at this concept of reducing the stress response, which is ultimately the aim of all the enhanced recovery programs, and trying to get our patients into the best possible way afterwards. So just a couple of very quick definitions, what is pain and what is nociception? So, pain is the conscious perception of actual or potential tissue damage, whereas nociception is more of a physiological response. So the patient has to be unconscious for us to detect nociception. And if we look during our operation, there are lots of noxious stimuli that happen. Intubation, skin incision are all very, very stimulating. But the problem is that we get changes in autonomic response, such as changes in our heart rate, blood pressure, pulse pressure, but we often, are very slow to pick these up usually. And the analgesics that we use are based on our own experience, our own knowledge of previous surgery, and so therefore they're very subjective. And as I've mentioned, we don't really have a real-time indicator. So the null monitor, which is made by an Israeli company called Medisense, and is being sold and marketed by Medtronic, has been around now for 6 or 7 years. It involves placing a probe on the patient, very similar to an oxygen saturation probe, and it uses the following characteristics to come up with the null index. So temperature, galvanic skin response, looking at sweating. It has an accelerometer in, and it uses photoplethysmography as well. And then there's lots of artificial intelligence, which gives you a null index. If for those of you who are interested, this was the paper from 2013, which showed how the null was developed. And to sort of summarize in this slide, they went into the operating room with patients undergoing surgery, elective surgery with fentanyl or remifentanil, and then they looked at the following parameters: skin conductance, heart rate, pleth amplitude, and heart rate variability. And each of these inputs was put into a model, and the best relationship between these parameters and the CSER, which is the combined index of simulation, was explored. So the CSER is basically a simulation intensity that's graded from 0 to 10. So intubation sits in the middle around a 6, and a skin incision is around a 3. And then you minus the opioid, as you can see from the formula down there. And what they showed in this particular paper is that, and if you can see my mouse, that skin conductance and pleth amplitude here didn't show a very, very good response on this ROC curve. Heart rate showed a slightly better response, with heart rate variability being even better. But the best two lines on this ROC curve were the null, which basically seemed to predict, patients feeling nociception very, very well in this particular study. So the null index, we have two kind of areas of interest. There's the null, which is less than 25, which suggests that the patients have sufficient analgesia on board. And then we have a value above 25, and you usually have to wait for 2 to 3 minutes, which suggests that the patient is getting clinically relevant nociceptive reaction. And that might be pain, but it also can be other stimuli like pressure. And you need to decide as anesthesiologists whether we need to intervene at this stage. This is a review paper from British Journal of Anesthesia from 2019, which looks at nociception, and this is a really nice paper to have a read of. Talks about single parameter, 2-parameter, multi-parameter null monitoring. But what they do say is that quantifying nociception and analgesia remains the holy grail in anesthesia monitoring. And I'd really urge you to have a look at these monitoring devices and have them in your anesthetic practice. So what would I say is the clinical value of null monitoring? Well, these are 5 things that I think really have helped me over the last few years. I feel that I give patients a much smoother, personalized anesthetic regimen. I can safely titrate analgesia in high-risk patients. I hope that we can improve postoperative outcome. One thing, I do a lot of regional anesthesia with nerve blocks, and it definitely confirms the effectiveness of my my nerve blocks and epidural analgesia. And again, for those of you who do opioid sparing or opioid free regimes, you know, you can keep a monitor of nociception whilst you're undergoing these. So I've been using the NOL mainly in major orthopedic and trauma surgery, as I mentioned, in regional anesthesia lists. And up until recently, I was doing elective and emergency general surgical cases as well, where I was using NOL in these contexts. The problems we have in major orthopedic surgery is that we've got elderly patients. They've often got complex fractures, significant comorbidity, and we're very, very nervous about inducing or worsening pre and post-operative cognitive disorder. And I'm going to spend a bit of time talking about that. This was an abstract we published in Journal of Intensive Care Society a couple of years back, showing that, you know, we have a significant amount of patients. In 1 year, over the age of 80, we had 155 patients coming to our ICU, you know, with a mean length of stay of just under 2 days. So this is a big problem in the UK, the elderly complex patients. So just to talk very, very briefly about postoperative cognitive disorder, or POCD, again, the nomenclature and how we describe these changed in 2018. And these are the 3 sort of very relevant publications that, that go through the name changing. But essentially we have postoperative delirium, delayed neurocognitive recovery, DNCR, and then postoperative neurocognitive disorder, which can be classified into mild and major. What we would really like is our patients to emerge from anesthesia and have an uneventful recovery and be discharged. But what we do know is that the elderly can suffer delirium in the days following major surgery. In the weeks after, they can have the delayed neurocognitive recovery, and sort of weeks to months, they can then get postoperative neurocognitive disorder. And the link is not fully there yet with dementia, but you can understand that dementia can, you know, can potentially be attributed to anesthesia, which can happen years and years after. So if we look at postoperative delirium, the ways that we could potentially affect it intraoperatively is using the optimal analgesic techniques, not overdosing our patients. We can avoid the use of strong opiates and benzodiazepines, and we can also use regional anesthesia techniques if possible, whether it be spinal or epidural, as well as nerve blocks. So I'm now going to describe 3 cases which have got high-risk elderly patients in, and how I've used NOL as well as processed EEG to improve these patients' outcomes. So the first case study is a lady called Pamela Ford. So she was 88. She had a fall at home, and she got a very complex periprosthetic fracture, and she developed a pneumonia on the ward. For those of you who like looking at X-rays, this is actually where her fracture was. So the right side all the way down the femur, which would involve the all these prostheses having to come out due to loosening. On the day of surgery, when I went to see her on the ward, she had a heart rate of 100. Her blood pressure was, as you can see, but worryingly, her saturations were 86% on air and only 90% on 4 litres of oxygen. She had a pneumonia, and she'd been immobile in bed for 6 days. She'd actually been declined by 3 of my colleagues due to high risk of anesthesia. So it was kind of left to me to anesthetize her. So the technique that I involved for this lady was I took her to the anaesthetic room. She had an arterial line placed. She had BIS sensors put on, as well as the NOL monitor. I did a remifentanil induction with propofol and rocuronium. I then turned her onto her side, placed a lumbar epidural, and started a metramnol infusion. This particular lady was run on isoflurane throughout the case. This is the setup in theatre. we can see I've got the BIS monitor integrated into my monitoring, and she's got remifentanil and metronidazole started here. She's got an arterial line, gas monitoring, BIS monitoring, and the null monitor is there. So you can see here in real time kind of how the null looks and how it compares, to the other monitoring that we're used to. So through this case, I ran her on a remifentanil TCI of 1 nanogram per mil. She had an end-tidal isoflurane of 0.4 with an age-adjusted MAC of 0.4, and she had an epidural that was running. And in our hospital, we use a combination of 0.1% bupivacaine with diamorphine, and that was running at 4 mils an hour. So this particular slide, what I want to highlight really is about how quickly the null can change. So the epidural had been placed, there was nothing running through the epidural. So at the start of the case, the surgeons are lifting the leg of the patient to do all their prepping. And you can see how the null value jumps up very quickly, 36.41. And if I pan up to where her observations are, you can see at this stage that there's no change at all in her observations. Heart rate's 48, blood pressure is very well controlled, stats are very well controlled, and she's got an end-tidal MAC of 0.3 at that stage. So the null gives it a very, very quick increase when patients are feeling nociception, and at that stage, I gave her a bolus down the epidural. So her outcome, she had 6 hours of surgery, she was extubated, went to the critical care unit, she was pain-free, awake and alert, and she was very stable for the next 2 days and didn't require any vasopressor support at all during that time. So again, I feel that I optimized her anesthesia by running her, on a precision anesthetic technique with a very low end-tidal isoflurane, with optimal analgesia, and kind of she had a very, very good outcome. This was her 4 days later. She was mobilizing on the ward. And this is here 3 months later when she came back to clinic, doing very, very well with no problems at all. So this, was a huge success for someone who, if we'd have left, would have died. The case study 2 is a lady, again, she's 84, she weighs 50 kilos. She's got an ASA score of 3. She had an emergency laparotomy. She needed an emergency laparotomy, and she'd previously had 4 laparotomies in the past. And she'd got a closed loop obstruction on CT and needed to go for an emergency case at 11 o'clock in the night. Again, she came to the anaesthetic room, we put an arterial line in, she had BIS and null monitoring. I placed a thoracic epidural in and then did a TIVA induction, remifentanil, propofol, and rocuronium. And we took her into theatre. So during this anaesthetic, she ran on a remifentanil TCI of 1 nanogram per mil. She ran on the Schneider model of propofol, 1 mic per mil. I kept her BIS in the range of 50. And she had a thoracic epidural, as I said, at a level of T8T9, which was running at 4 mils an hour of bupivacaine and diamorphine. So this is some of the data that you can now get from the null machine now the software has been upgraded. And I was going to talk through some of this now. So she had her GA TIVA induction at this point here, and you can see the red is where she's feeling some stimulation. The big spike is intubation there. You can see how stimulating that is. We positioned the patient just here. I gave her an epidural bolus before the surgeon started at this point, 11:30. And this is where knife to skin was. So again, you can see that there's a huge response once the surgeon started operating. And again, this is just because the epidural doesn't have time to start working. So at this point, I increased the remifentanil and I got it to a nice dose. And then over time, as the epidural starts to work and the case is ongoing, so this is about 45 minutes later, you can see that the null value drops right off. So I can decrease her remifentanil at this point. And again, this is her running at 1 nanogram per mil. And there's a small spike there. There's a couple of smaller spikes during the case, which I feel just represented pressure. And there's a bigger spike towards the end of surgery now where they're closing the abdomen, which I'm convinced is a pressure phenomenon more than anything else. And then we woke her up at the end of the case. Okay, so this case finished at 2:17 in the morning. So roughly, 3 hours later, 3.5 hours later, she was extubated, went to the critical care unit in the middle of the night. She was completely pain-free. She was very awake and very alert. And again, importantly, she didn't need any vasopressors for the next 48 hours while she was on the critical care unit. So again, I feel that this lady was someone who was able to use the null technology to completely optimize the amount of analgesia from her epidural, and also from the remifentanil, and not overdose her, not give her too much, but just kind of what she needed. And she had a very, very good outcome as well. Okay, the final case I'd like to talk about is this particular patient, Mr. GW. He was 82, and he had fallen 10 months previously and got a very nasty non-union of a humerus fracture. This was very disabling for the patient because he used a stick for mobilization, and his exercise tolerance was about 50 to 100 yards. That's a picture of his x-ray, so you can see a very, very nasty humeral fracture. But of note really for anesthetic problems, he was an elderly patient. He'd got significant comorbidity. He'd had a previous stroke. He'd got ischemic heart disease and respiratory disease as well. The main problem for us is that we need to sit him in the beach chair position, and the surgeons told me that there was a high degree of probable intraoperative blood loss because this was an old fracture. So I would just want to spend a couple of slides just talking about cerebral oxygenation, really, because what we do know is that when we sit patients up in the beach chair, we can decrease the blood flow to their brain, and therefore we can put them at risk of having cerebral events. And this particular paper from Anesthesia Analgesia showed that patients who were in the beach chair group there in the red box had a very high incidence of cerebral desaturation, up to 80% in this group. And that can be a real problem. So for this particular patient, again, I induced him with BIS, null, and I've put INVOS there. So INVOS is cerebral oximetry monitoring by near-infrared spectroscopy. He had a TIVA induction, he had a rocuronium bolus, and then he had a supraclavicular nerve block placed. And during the case, I was monitoring his bispectral index, his null index, and his INVOS. So this, the same theatre, now the setup is slightly different. We have BIS being monitored here. We've got INVOS and cerebral oximetry being monitored here. Null is here, and you can see my TIVA setup just here. So he was running in theatre with a remifentanil TCI of 2 nanograms per mil. Again, very, very low propofol, 1 mic per mil Schneider model. And he'd had a supraclavicular nerve block with 20 mils of 0.5% levo bupivacaine placed. So if we go and look at his null data, you can see this is where we put him to sleep. He was intubated here, which again shows a big spike. And again, he wasn't a difficult intubation, but it just shows how stimulating intubation can be. I placed the supraclavicular nerve block at this point here, 11:05 in the morning. He was positioned into beach chair, and at this stage, the surgeons wanted to do an EUA of his arm to see how mobile the fracture site was. So by the time we got him into theatre, he was very stable. His null had dropped off, I think, just reflecting how effective the supraclavicular block was. This was knife to skin, and you can see there was a small spike of null here where I just increased his remifentanil just there. Just to show you how the INVOS sits, so BIS monitoring is here, and the INVOS again is just skin probes just going over the frontal part of the head here, which are reflected in this monitor. Very quickly, again, for those of you who haven't seen this particular monitor, what I just wanted to show you here was this point in time here is the patient has been anesthetized, he's been pre-oxygenated, he's been ventilated, and this very, very steep drop in his oxygen saturations, this is what happens when we raise him into the beach chair position. And you can see that for me to get him back into this normal range here, and this is monitoring left side of the brain, right side of the brain, with the percentage drop here, took me to keep his mean blood pressure at 106. And again, for this particular patient, I would never have thought of raising his blood pressure that high, but he'd had a previous stroke. And again, you can see here that he's definitely got problems on the right side of his brain with a reduction of 12% here versus 8% here. The null monitor here, you can see is 13, so it's less than 25. And again, it's running very, very continuously throughout the whole time. And I've got him on 2.5 of Remy there, which is I've just increased at that point. So this was the plate that the surgeons put in, they've nicely reduced the fracture. And again, he had 3 hours of surgery, he was extubated. And again, he spent 2 days in hospital, but he went back to the ward and he was ready for discharge the next day. He was just kept on the surgical ward just for social reasons, really. So kind of just to sort of sum up really where we're at with this, you know, my observations on null, it gives us a very fast response to a noxious stimulus where we can up and down titrate remifentanil very, very quickly. We can also add in longer acting opiates if we need to. And again, you know, it's important for us to wait for the peak effect of the opiate to work. So when you give morphine or fentanyl, you've got to wait a decent amount of time, and then you'll see a very nice response in the null. As I hope I've reflected in this talk, the effectiveness of regional anesthetic techniques can be monitored very nicely, whether it's an epidural or whether it's a regional block. I feel it has to be used in combination with processed EEG to get the best of this kind of precision anesthesia where you can regulate the amount of hypnotic agent you're giving, and it can be volatile as well as intravenous anesthesia. And there is no doubt that the null value does increase when the heart rate starts to increase and that blood pressure starts to increase. The null value goes up, but you'd expect that because the probe is picking up values, you know, to do with photopleth and everything. So patients will feel stimulus during the case, and you will see some changes in physiology as well. I think the future, again, is going to involve, you know, a lot of advanced patient monitoring, you know, processed EEG, null monitoring, and super oximetry. And this is a paper from a Chinese group which kind of talks about this from July 21. And again, just in summary, these are the areas that I feel null monitoring will help us going forward. It allows us to give a smoother, personalized anesthetic technique, safe titration of drugs, improve post-operative outcomes, confirm the effectiveness of our regional anesthetic techniques, and it'll help us to validate multimodal and opioid sparing and opioid free regimes moving forward.